I'd like to welcome you to Question Time from Belfast. And on the panel this year, from my right is Henrik, as we know, Chair of GDPC. Next to me is Colette Bridgman, Chief Dental Officer of Wales, who was involved in the pre-piloting process, figuring out how the pilots were going to work, when prevention was certainly a higher priority at that stage. And she obviously has setting up her the contract reform in Wales. To my left is Claudia Peace, who is an associate in prototype practice in Hampshire. And beside her is Eric Rooney, Deputy Chief Dental Officer of England, who's just produced the first prototype evaluation report just in the last few weeks. And then we know Stephen Fail, who's just addressed us this afternoon. So I'd just like to kick things off with a question to Colette. What would you suggest would improve the delivery of prevention in a reformed contract?
Hello, can you hear? No, I don't think it's on.
We get the mic. It's on?
It is on?
Yeah.
Right, good afternoon, everyone, and it's absolutely fantastic to be here in Belfast. It's my home city, and thank you for the question. I think when I was listening to Stephen speak there, it really reinforced my feeling about what we know is prevention works, and he illustrated that. And when he mentioned Child Smile, and he put up figures from 2013 of a 41% of children, 5% of children affected. The last figures, just this year, that's now down to 34%, so we know prevention works. You also mentioned about how disease is polarising, and where you can target deprived areas, as Siobhan mentioned, that's where we can do it, it overlaps. We've got dental practices in every village, in every town, in every city. And if we don't get this prevention working, happening every day, happening and having a contract that supports that, we just aren't delivering what we should be and addressing inequalities. So sometimes I have to call the programme contract reform, but I don't really think that explains what we're doing in Wales. I've gone back to the first principles of those dentists that I work with in Oldham and Salford. We started by understanding the needs of the population that those practices were serving. You can't plan services unless you understand what those needs are. And then you need to wrap a contracting process around that makes that happen. Building in incentives, building in quality measures, and making sure we're delivering value for money. So how we're trying to implement getting prevention into practice in Wales. We've spent the last year developing a toolkit so that we can understand and report need at a practice population level. It's an indicator of need. It's not epidemiology. It's light touch. And it's now embedded in an FP17, just 7 data points. It's really straightforward. Mick calls it my tangerine dream, the new FP17 for Wales. And this isn't an exclusive club. We've got 23 practices who've started this process with us. But there's nothing we're doing that the rest of the 400 can't be looking at and testing and starting. We're using a test modify, means that if something's working, we spread it, we validate the good practice and get it out there. And just this week, I've had the first results back from quarter four of last year and quarter 4 of this year for those 23 practices. We've got a really good indication of the needs, differences across the practices, and I think that's going to change the conversation. The health board people sitting around with me with the practice in Swansea on Tuesday night were actually looking and saying, well, that's very different. Those needs in that practice, how can we then, it's not a one-size-fits-all. Some may need a further reduction. We've given them a smaller bit of headspace and headroom just to collect the needs assessment. We might need to go to much further reductions. But I believe every system is designed for the results it gets. So we want to see prevention, we want to see better outcomes, and we want to see valued, engaged, happy dental teams. So we need measures that measure that. and that's what we're trying to design. And going into the next phase of this, we'll be designing those measures. Does that...
Thank you. Thank you, Colette. Sorry, I also meant to mention, we obviously will welcome questions from the floor. There is a microphone, number 1, sitting to the right centre. And so if you wish to ask a question of the panel on the topic of contract reform, please stand up, state your name and your LDC that you represent, and we can take your question. So I'd just like to ask Colette, what would you suggest? Oh, sorry, not Colette, sorry, that's my mistake. What's your experience, Claudia, of working as an associate in a pilot and then a prototype practice?
I think when we first went into the pilot, we probably really looked forward to the whole thing. We were very glad to get rid of the UDAs. From an associate's point of view, just as a performer, it was fantastic to suddenly have the emphasis on prevention. Delivering better oral health was our touchstone, and to have the time, because we increased our examinations by 5 minutes. We had these social questionnaires, which really gave us a lot of information about the patients' diets, and we could see where we could work with them. And it was fantastic. And we could spend time teaching them how to brush their teeth. And then the prototype came and activity was introduced. And I have to say, it really skewed in our practice, our associates' mentality. Suddenly, we really felt the pressure. We were back on that treadmill and the cogs in the wheel, and we were having to do it quicker to get more access. And as a consequence, it's been diminished. The whole process of the prevention message has been diminished. And I think most of us see prevention as part of our professional working life. You know, it's a marker of quality. And I really gained that during the pilots. And I have to say, I've lost quite a lot of that now. And that's been a great disappointment in the prototypes for me.
So, Eric, you've just produced the evaluation document. It's given 17 recommendations. How long is it going to be before maybe we can see those recommendations coming into action?
So I think the recommendations are of a variety of different types, and I think undoubtedly some of them would be much easier to introduce than others. Some of them are recommendations about further information, further evaluation. So, for example, on the issue that everyone's talking about here today in terms of prevention, then there is this concern, and you may or you may not be aware, but before the publication or the development of the report, then we held a number of engagement events with people involved in the prototypes in order to let them see what the data was showing and to get qualitative feedback from them about how they felt things were happening. And one of the things which came up in those events was the very points that you've made, Claudia. And so the report itself reflects that and picks that up. And a couple of the recommendations that are in the report are around doing some further investigative work, not just with practitioners, but also with patients around the prevention that has been going on during the prototype process. And I would expect that that is a relatively straightforward thing to do in terms of following through really a questionnaire approach which was done very early on in the pilots and would allow us to compare with that. But I think it's really important for everybody in the room to understand that within the mix of people in the contract pilots in England at the moment, there are two distinct groups of practices. There are those practices who entered into the process having been previously in pilots like Claudia and others, where during the pilot phase of the programme, the number of patients that were being seen in those practices and the clinical activity that was being done reduced gradually over time from the point that they started that process. Now, when they came to become prototypes and come forward to be prototypes, obviously levels of number of capitated patients, depending on their blend, and activity, depending on their blend, were set for those practices. And as a group, by and large, most of those practices needed to increase the number of patients they had and the activity which had been going on in the previous period. The other group who are in the prototype contract arrangements are those who entered in directly from the current 2006 UDA system. And their baseline, if you like, was taken from, again, what they had previously done before that. But in recognition of the fact that prevention and the risk aspects that Colette was talking about take a bit more time, the number of units of activity, the activity measure, was reduced by somewhere between 25 and 30% to take account of that. So I think it's definitely unfair, in my view, to say that the objective of prevention is not still at the heart of the reform contract program we've got going in England. The report says that, by and large, and somebody from the podium mentioned it earlier on today, that the profession still like that pathway approach. The intention is you do your assessment with the risk assessment, as Colette has mentioned, with delivering better oral health, prevention then implemented, as Claudia has said. And that is still at the heart of the actual clinical model of delivery. And when we look at the process measures around that, then the evaluation report supports that those things are happening. But what the report does say is that you might call it the commercial model. In other words, the way in which the funding and the counting and so forth is working. The conclusion is that we're not at a point where that would be suitable for rollout.
Thank you. Can we take a question from the floor? Just declare your name, your LDC, and who you would like to address your question to, please.
I'm Richard Grant. I'm from Northumberland, and this really is for anybody on the government side from the department. I've been in this game an awful long time, probably longer than almost everybody, with one or two exceptions in this room, and I've seen it all before. There's nothing new under the sun that I haven't seen before. My question is taken from a position of stepping back and looking from a much wider viewpoint. Forget the little details. Forget the fine details that we're discussing this afternoon. I'm stepping right back. I'm stepping beyond this room, stepping beyond the country. I'm taking a galaxy.
Sorry, Richard, can we have a question, please? We need to move on.
It's coming now.
No, please, question.
Does the department have the appetite to go to the Treasury, demand more money, and does the department have the appetite to develop the sort of dental health services that the patients of this country require?
So I can't speak directly for the department. I could speak as an advisor in NHS England and to the Department of Health. And I can assure you that from my personal perspective, then I am doing everything I can in order to ensure that dentistry is recognised as a key part of the NHS going forward. You may or you may not know there are lots and lots of changes happening. I think if you heard the news last night about Simon Stevens and potentially, because the NHS is 70 years old this year, some further money for the NHS and some discussion with Theresa May about that, and then the Treasury trying to perhaps screw that down. That was what the BBC News was saying. That's the climate and the situation that we are in. But from a personal perspective and as a dentist, then I am doing whatever I can to ensure that we are at the table and part of that developing discussion.
Thank you. I often get money as a birthday present, and it doesn't last very long. So.
I absolutely agree with the question that we need more money for this. There are several reasons for that. One is the obvious one, that we are at the moment only treating about half the population on the NHS. So if the aim is that we should actually go out and give a comprehensive NHS offer to the whole of the population, then we are missing out on a lot of money. But also, it's very, very clear from what we are seeing now with the prototypes that there are too many of them that are not hitting their access targets, and there are too many of them that are facing clawback. Can I just say one thing on the pilot practices? There were some pilot practices that weren't allowed to go into prototyping. There were some that were allowed to go into prototyping, but generally the pilot practices have been treated very, very badly. To start with, they were told that it's a question of how much time you spend doing NHS dentistry. There was no mentioning of access targets at all for the pilots when they started. And I have to be honest with you, NHS England, or PCTs as well in those days, and the Department of Health have treated those practices very badly. They are desperately trying to catch up on their access targets, and they should actually get some help. The whole system needs to be looked at when it comes to the business model as such, and that's what Eric says, and that was one of the recommendations in the report. I like the thing about a bit more headspace. I'm not bothered what we call it, how we are doing it, but the problem is that doing the prevention actually takes time, and doing the prevention means that it is difficult for a lot of the practices to hit their target, and that's the problem. And I cannot understand why NHS England cannot see that. It seems to be obvious to people in Wales, but I don't think the dental needs in Wales are that different from the ones in England. And what we need is the business model to be sorted out, because the clinical model seems to work. That's what we hear from practices. So they need to do something about it, frankly, now.
I just want to add, when Eric was speaking, I thought about when I came to Wales, they had a very similar experience with their pilots, and they had about 15 practices in, saw falls in access, falls in activity, and all bar 2 were stopped. And I really tried to understand why, and I think because they were doing the right thing, they were doing what they were being asked. But I think what we've missed here is it's a whole system approach. You can't just take one measure of something and hope to see what you want. And in this newer piloting process, we're starting with needs. It's also about, it started as a workforce project, and I think we're returning to that. In Wales, we've got this approach called prudent healthcare. So sometimes it's about more money, more investment, and sometimes it's about using the investment we have more effectively, better value. Value-based healthcare is something that the Welsh Government are very strong on, and dentistry is not immune to it. And what is clear to me, even looking at the first returns of these new pilots, is how much investment we need to make in additional skill mix. So Welsh Government understood that, and they're putting together an innovation fund. So practices will be able to bid to increase their skill mix. And what I hope we'll see is the distinction in the patients. So those that have higher needs get more time, get more, and a lot of that can be delivered by dental care professionals. And those who have lower risk, lower need, again, it would free time up for dentists to perhaps increase access. So it's a whole system approach.
Thank you. Can we take another question? Sean Charlwood.
Yeah, thank you, Joe. Sean Charlwood, Lincolnshire LDC, GDPC. A question, I suppose, for Eric and Henrik. Stephen made the point repeatedly that prevention is an investment for the future, and the benefits will only be apparent in the future. But we also heard from the prototypes that the first thing that gave chasing activity and access was prevention. So how are we going to embed prevention and be able to protect the time and the resource for practices to deliver the prevention that we so patently need?
I mean, I think to an extent, when I told you about the UDA practices, or the practice coming from the UDA system, then there's clearly an intention there to free up some of the existing resource and focus that on prevention. I think the other thing which exists within the pilots, which, and I know some people, it depends, I think, on individual practice circumstances, may feel this is or isn't something that is helpful. But although there is an activity target within the prototypes, my clinical view is that whilst you may have a certain cohort of patients, a number of patients, etc., and that will change as patients leave and die and new ones come in and so forth, that it's actually pretty impossible to predict exactly what the clinical activity measured in UDAs actually is to service that particular population. And I was really concerned that people would go, and unfortunately I think I hear it when we had the engagement events, go chasing UDAs in order to meet that target. So there is within the system an opportunity for people to do less than the expected number of UDAs, but in return take on more patients, and there's a conversion factor associated with that. And I think, Colette, some of your work has showed that you've been able to take on some more patients in your new pilots.
Yeah, my experience of that, wave 1 and 2 practices are struggling to see the patients that they've got to take on additional patients to meet these UDAs, which I feel are completely counterintuitive to any kind of prevention. Activity is counterintuitive to any kind of prevention message. Doesn't make much sense for a supposedly reformed contract. Paul McCrory.
Yes, Paul McCrory, Barry, Rochdale, Haywood and Middleton, LDC. Earlier, Stephen mentioned return on investment for prevention. Henrik's mentioned that the financial model is what needs to be sorted out for a new contract. It strikes me that there's a bit of an antagonism between the current styles of contract and what you're hoping to achieve in terms of prevention. And what I'd like to know is whether there's any proposals or there have been any discussions on the possibility of having longer-term payments which reflect outcomes, so that if a practice produces long-term benefits for the local population, will those providers be remunerated, or preferably the performers be remunerated, because if they're incentivized, so it could be through their pensions being enhanced perhaps, or it could be through some sort of delayed payment. And the second thing is just...
No, just one question, Paul, that's all. Sorry.
Sorry, Eric more than that.
Eric, right.
So some of you may know, in the original configuration of the prototypes and within the pilots, as well as the delivering the clinical pathway and so forth, the mood music, I think, politically, when we first started all of this, was very much about outcomes and paying for outcomes. And so there existed and exists something called the Dental Quality and Outcomes Framework. And that has a number of different sections within it in terms of clinical outcomes, safety outcomes, and patient experience outcomes. And we all know that through the whole period, the software support, I personally believe we've always had some difficulties with some of the software aspects that support the pilots and subsequently the prototypes. And the data quality of the information to support that dental quality and outcomes framework was not really robust enough during the pilot process to assign payment to that. We did get to a point where the quality was good enough to report it, and it was reported for the first time with the prototypes in their first year. But I think going back to the mood music, because of other things within the wider NHS, and particularly the GP quality and outcomes framework, I think we've all probably begun to move away from the idea of actually paying on that, which is what your question is. And part of that is because, again, in the engagement events and through the NSG with BDA, the complexity of trying to balance 3 different indicators, which may vary in terms of what your ultimate year-end position might be, is really quite complex. And therefore, the general view, I think, going forward, although it's not decided, is that we should stick with the DQOF, and there is a subgroup of the dental contract reform programme, which is looking at the DQOF with professional input, BDA and others, to see how we keep the DQOF, but we use it perhaps in a more supportive and audit and peer review type way in order to ensure and encourage quality.
Thank you.
Well, I actually, I'm not keen on paying on too many different things generally. I think I generally trust my colleagues. So actually, if we get some money and we look after some patients, then I think we generally, the vast majority of us, will do the right thing and will do the prevention. The problem we're having at the moment is that practices are chasing around trying to get activity targets, which we don't want. We want them out, we want the fully capitated system. And also, they haven't got the time to do the prevention. They are hit on their access targets, and that is not reasonable. They're doing a good job, they should be paid properly for it, and then we will look after our patients, and the results will follow.
I agree with you. So, what we've just seen from the first returns in Wales, and I think is right, that little bit of headspace, that little bit of headroom with a 10% reduction of one target while we design what we are going to measure with, has produced 4.58% increased access. Dentists are doing the right thing, a little bit of prompting. There's been an increase across the board of over 20% in fluoride varnish applications, and we haven't even moved yet into transforming the services, giving them additional investment for their skill mix. So I totally agree. I think sometimes we design contracts or measures to catch people out rather than to incentivize good service and what we want to see.
Yeah, we have just started an outreach to treat the homeless in Winchester, and we've got involved with a local charity. And I went to talk to them about what they needed, and they didn't actually need treatment for emergencies. That was already covered by NHS England. What they needed was prevention. So we're going in there once a month, and we're talking to their groups. But of course, the trouble is there isn't the joined-up thinking. So we're not getting paid via the prototype. There are small lump sums, I think, to be paid for it. But obviously, we've got time out of practice, and we have actually increased our capitation numbers over 100%. But it's got to the point that I've always stopped thinking about my capitation numbers, and I'm prepared to take the hit because I want to do the dentistry. I want to do that prevention. I think getting out to these vulnerable groups is really important as part of general practice, not just the community services. But it's a shame that it's not all linked up for the payment system.
Thank you.
Can I take another question from the floor? I'm not sure who you are, sorry.
Nick Patsius, Bromley LDC. My question is, when is the department going to start supporting dentists? We're currently having to work with one hand severely tied right up our back. Number one, by DNAs. Many practices are having to still suffer 25% DNAs, and we were stitched up with that with the 2006 contract where no extra funding was given to us by the fact that a lot of whenever somebody doesn't turn up, we can't earn money. And the other thing is with 600,000 patients going to doctors at £50 a time, with another 150,000 going to A&E at £150 a time, all that money could much better be served by putting it into the dental service. So when are you going to change something or talk to the powers that be to help us, just for once, do our job properly? Because it seems at the moment we're always trying to do things the hard way.
Eric. Tough one.
So again, I guess I go back to how I started the other question, which is I am an advisor, so I can advise, I can give advice and say what I think should happen. What I do know, though, is that there are opportunities, because I work not just nationally but also locally, And in some places, this is happening. We talked before about recycling money from the clawback and so forth. There are teams across the country, NHS England commissioning teams, along with their professional advice, both LDC and local dental network, who are managing to put together various types of schemes in order to support delivery of care to the right populations in their area. And that's being done by being able to articulate what the issue is, what the problem is, and then managing to get that into the planning cycle within the local budgeting process. And so things which will enable, for example, the Start and Well program that you heard about before that Stephen mentioned, that's based on some additional resource going into those practices in order to give them a similar kind of headspace, if you like, to be able to work outside the practice with the most vulnerable children, etc., to improve their health. So there are ways of doing it, and it's not all national. And I guess when we talk tomorrow about devolution, we'll be talking some more about that in terms of the way that, particularly in England, things are shaping up.
Thank you. Stephen, sorry, I just wanted to bring Stephen in. You've fallen asleep there, poor chap. But Eric mentions Starting Well, and you just spoke earlier about Child Smile and Design to Smile. Design to Smile and Child Smile seem to have support through the schools. Dental practices, it seems to be a 2 or 3 pronged attack there, whereas Starting Well is a practice-based system. Is that limiting the potential, do you think, of the preventive element that Starting Well could actually provide?
Sorry, nobody's answering my question.
Sorry.
We were supposed to be talking about DNAs and the department helping us to do our UDAs in some way, but we never see them helping us in any way. It's just putting our arm back up our backs to make it difficult.
I think your question was particularly about patients who turn up at A&E and go to their medical practice.
Well, that was one of them, yes.
And we all understand.
When are we going to be helped in what we're doing?
I probably feel a lot of frustration and sort of irritation when I hear people talking about the NHS being free at the point of contact. And we don't always hear them say, except for dentistry and NHS dentistry for many people. And I think sometimes we need to perhaps, in policy terms, understand how we change those barriers. And I think that's a lot of reason as to why people turn up at A&E and turn up at their medical practices. And that's going to take some interprofessional collaborative work and support for dental practices.
They turn up because it's free. They have to pay to come and see us. They turn up at the medical.
You asked the question. Let Colette give the answer if you can. Okay. It's not a conversation.
Okay.
I was going to finish by saying that those are one of the group of people who don't attend routinely, who don't sort of follow what we'd like them to do and value their teeth quite in the way we would want, where we have to do special design of services and planning. And I think we're maybe not very good at delivering what matters to people and when they want it and where they want it. And I think it is a challenge for NHS dentistry to do that. I haven't got the full answers. It happens in Wales, but maybe not to the extent that you're suggesting.
Okay, thank you. Can I take the next question?
Mick Horton, Chair of North Wales and Dean of the FGDP. Today we're only halfway through the first day of conference and we've heard a sea of opinion that all seems to point towards prevention. We've heard Stephen that's given evidence that points towards prevention. We still have a perverse system that measures interventions. We do not measure prevention. We don't actually say how many times did you actually prevent something occurring. What we actually do is say how many times did you take a drill and put it in a tooth. And until we actually get a system that stops measuring how many times we pick up a drill and starts measuring how many times we stop us picking up that drill, we will never actually get the correct system. So with what you've actually talked about today, and I know we've had conversations previously, how does the changing system address that and actually stop us picking up that drill in the first place?
Who'd like that?
needs and risk assessment.
I mean, I suppose, Mick, the capitation, and there is a fundamental sort of mindset thing about this. If you believe in capitation, then yes, you can measure the prevention. So we do. We measure the delivering better oral health adherence to best practice in that. We measure the numbers of courses of treatment that have fluoride varnish in them per 100 courses of treatment, etc. So you can measure it. In our version of the reformed contract, then we are putting that into the capitation element of the bundle. And in the bundle, in the two blends, just again for information, the capitation forms the larger proportion of the fund in both the blends. So 60% roundabout and 80% roundabout. But one thing that I do sometimes worry about, and I guess it comes back to some of the discussion around maybe the UDA system and the granularity of that. I think you either have to have a mindset which is, I'm going to do prevention and it's part of this bundle of money that I've got for this patient, or you go completely to the other extreme and your head's in the place where you need to see the actual reward for that individual activity, in which case we'd be back to the SDR for preventive things. Preventive items, they are interventions of a sort, and you could do it that way. And sometimes I do worry that, and I know the BDA's position is generally around capitation and that approach and the freedom that brings, and I do understand that, and I would be with that. But I do wonder sometimes about our profession and whether, because of the history of the way that we were historically paid, we're able to actually operate in that way.
I think it's a really good question, and I think it's where you start with a needs assessment so that you understand if someone has active disease or not, and it tailors your personalised advice. But something that I think we also need to be very clear about, it's not all just about prevention. It's really important. It needs to be integrated. Dentistry is absolutely fantastic at treating disease, and it contributes to improving health. So I think the fact that we can take a needs assessment and do that for an individual and then repeat that a year later and so on and so on, the prevention will contribute, but so will quality, good dentistry and good treatment. And I think we should be very proud of that, what's delivered in NHS. And we don't really measure just how much of that improves health. And by linking one oral health needs at risk assessment and the second and consequent, you will be able to track improvement over time, not just the number of fillings that were done, but the fact that that active disease is managed.
Can I just say that I don't know how many of you saw a press release from the Chief Dental Officer about a week ago about starting well, where she challenged the profession to see, how much was it, 70,000 more children under starting well. I hadn't heard about it, I only saw the press release. There's no new money in there. I think you're going to produce a leaflet on it, but I think that is it. I think that's a wrong approach. One, because she's actually leaving it all at our doorstep to go and get those 70,000 children. But secondly, this needs to be a coordinated approach. We need the health visitors in there, we need the GPs in there, we need to get everybody involved in this. We can't go out on the street and start grabbing children and pulling them into the surgery. It is completely ridiculous. And if we are going to solve this, I have to say I was very disappointed about the press release, particularly since none of us knew anything about it. I think we need to work together and coordinate these things if we are going to get any impact of this whole thing. Don't leave it all at our door. It is a coordinated response, and actually NHS England and Department of Health really need to pull their act together.
Thank you. I think time's, sorry, Eric.
Can I just respond to that? And just again, I think there's also some elements of confusion out there. So there are two elements of starting well. There is a programme which is focused on the 13 areas in the country, local authority areas, which have the poorest, in the previous Children's Oral Health Survey, had the poorest children's oral health. And in those areas, there is a funded package, and it is about looking outside the door and going out and having the time and the headspace and the fund to support a champion, probably a DCP in the practice, who is able to work with the rest of that wider community. And when the survey that Stephen referred to, the most recent survey, came out, there are some case studies on the Local Government Association website, so not the NHS, which show some examples of what you were talking about before, Joe, the joined up aspect of not just doing it in the practice, but also the relationship with other activities and public health and community activities, which are there to support the improvement in the oral health of children.
Can I just take one? We're running out of time now. I'd just like to take one more question. Sorry, Eddie. Can I take it from Bruce, who's actually got a prototype practice? Sorry about that, Eddie.
Right. Bruce Porteous, GDBC, Lancashire LDC and the Sefton LDC. In any future, really this, Derek, in any future rollout of contract reform based on a capitation system, are we going to have some sort of national capitated amount that is varied by postcode for deprivation and DMF when first assessed? Or are we going to carry over corrupted data of contract values and historic out-of-date data about patient numbers that practice saw?
So in the recommendations of the report, both those issues are picked up in terms of the inequity which exists, which is because the funds are based on the historic translation that happened in 2006, and also on weighted capitation, which is the fancy word for what you're saying, which is to take things that we know which are likely to cause colleagues to spend more resource on treating those patients, to try and link that up in some sort of way. So weighted capitation and dealing with the inequity are both in the recommendations of the report.
Thank you. Time is upon us, as David Dimble would say. He never got the hassle that I just got there a few minutes ago. Sorry, Eddie, I really am. But no, that brings question time to an end. I'd like to thank the panel. I'd like to thank Stephen, who may well be available for magic tricks later on after dinner. I'd like to thank Eric and Claudia, Colette, and Henrik. And we shall meet. The next question time will be held in Birmingham this time next year. Tune in. #LDC Conf. Thank you very much.